This conference will now be recorded.
Okay, we shall start the class. So the today's topic is Lobar Pneumonia. So before going into the topic, we need to discuss about the normal lung parenchyma. This is the microscopic picture of normal lung parenchyma. Here we can see clear alveolar spaces which are lined by the alveolar epithelium, and few bronchioles we can also see. So what is pneumonia? This is the infection of the lung parenchyma, where whenever there is infection, there will be these clear spaces are filled with the fluid as well as the inflammatory cells. So the normal lung spongy consistency is lost and the lung gets solidified. That is known as consolidation. So consolidation of lung occurs in pneumonia. So what is consolidation? Consolidation is the exudative solidification of the lung parenchyma that occurs in bacterial invasion of the lung. So coming to the defense mechanisms of the respiratory tree. So the major is the nasal clearance, tracheobronchial clearance, and alveolar clearance. By all the three mechanisms, usually we'll get the defense mechanism. And by nasal clearance, the aerosolized particles carrying microorganisms are normally removed by sneezing and blowing or by swallowing. By tracheobronchial clearance, it is accomplished by mucociliary action. Particles are either swallowed or expectorated. And alveolar clearance, the phagocytosis of bacteria or solid particles by alveolar macrophages. Alveolar macrophages, otherwise known as dust cells, because they engulf the inhaled dust particles. So pneumonia can occur when any of these three mechanisms are damaged, or when the host immunity is lowered, or when the organism is highly virulent. So coming to the factors which interfere with the three defense mechanisms. So first one is loss or suppression of the cough reflex, usually seen in the comatose patients or the patients undergoing general anesthesia and neuromuscular disorders, drugs, and chest pain. And injury to the mucociliary apparatus, seen in smokers, corrosive gases, viral diseases, and certain genetic conditions like immotile ciliary syndrome. And impaired phagocytic clearance in case of alcoholism, cigarette smoking, anoxia, and oxygen intoxication, and pulmonary congestion and edema, and accumulation of the secretions. And cystic fibrosis is the certain genetic condition where there is the immotile ciliary syndrome. You can see there is increased secretions within the alveolar space, and those secretions are not get cleared off immediately. Coming to the etiology of pneumonia, decreased resistance seen in case of low immune patients, and virulent infection which causes lobar pneumonia, defective clearing mechanisms seen in comatose patients, paralyzed patients, smokers, and the patients with low immunity. Coming to the pathogenesis of pulmonary infection, the major step is entry of the pathogen. Entry of the pathogen is by aspiration, inhalation, inoculation, colonization, hematogenous spread, and direct spread. So pneumococcus pneumonia occurs usually by the aspiration of any food particles, which causes aspiration pneumonia. So pneumococcus pneumonia is the major causative agent of the aspiration pneumonia. And Mycobacterium tuberculosis and other viral pathogens enters via inhalation, and contamination, inoculation of the contaminated equipment. Inoculation is by the contaminated equipment, and colonization is seen in patients with COPD, and hematogenous spread seen in patients with sepsis, and direct spread from the adjacent abscess. So this is how the pneumonia lung look like. This is the lobar pneumonia, because only one lobe is involved here. Initially, the pathogen enters into the bronchiole, then enters into the alveolus, and after invasion, it gets multiplied. And initially, the alveolar macrophages which are present within the alveolar space, they engulf these bacteria, and there will be the process of exudation where the neutrophils enter into the alveolar space from the capillaries, and these neutrophils fight against the bacteria and engulf these bacteria. Later, after exudation, there will be process of opsonization by the neutrophils and resolution. In certain cases where there is virulent inoculation of the virulent bacteria or low immunity levels, there will be abscess formation. Coming to the types of pneumonia, there are various types: etiologic types, infective and non-infective, infective viral, bacterial, fungal, and tuberculosis, non-infective, toxins, chemicals, and morphologic types: lobar pneumonia, bronchopneumonia, interstitial pneumonia. Lobar pneumonia is the inflammation of the lung which occurs to the one particular partial or lobule of the lung. Bronchopneumonia, otherwise known as lobular pneumonia, and based on the duration, it is again divided into acute and chronic, and based on the clinical strategy: primary or secondary, typical or atypical, community acquired or hospital acquired. So coming to the lobar pneumonia, today's topic. Lobar pneumonia is the inflammation of the lung, occurs to the entire lobe or partial lobe of the lung, or two lobes of the same lung. Here we can see the process of exudation. Exudation is nothing but the fluid as well as the neutrophils comes from the capillary into the middle of the alveoli. Can you please move? %95 of the lobar pneumonia is caused by Streptococcus pneumoniae. So usually the clinical symptoms are high fever, rusty throat, and chest pain. There are 4 stages of lobar pneumonia. So there are 4 stages of lobar pneumonia. Stage 1, that is congestion. Next one, red hepatization. Next one, gray hepatization, and next one, resolution. So first one is stage of congestion. It occurs within the first to second day. And grossly, the lung is heavy, dark red, and firm in consistency. On microscopic picture, we can see the alveolar spaces. Alveolar capillaries are dilated. There is capillary dilatation, as well as the air space filled with the fluid, RBC and WBC. But the WBC is mild here compared to that of red hepatization stage, where the WBC count is elevated. So the patient presents with fever, cough, sinopathy, chest pain, bacteremia. And next stage is stage of red hepatization. It occurs in 2nd to 4th day. And grossly, the color of the lung is red in color and consolidated, just like liver. That's why it is known as hepatization. Normal consistency is spongy in consistency, which is lost, and the consistency is look like just like liver. That's why it is known as hepatization. And microscopically, the capillaries are congested, as well as the exudation of fibrin and large number of RBC. That's why it is red in color. And the patient present with fever, cough, chest pain, same as it of above. And the next stage is stage of gray hepatization, which occurs in 5th to 6th day. Grossly, it is dry, gray, firm in consistency, and the capillary is not dilated, and the alveolar space is filled with the neutrophil and excess amount of fibrin. That's why it is gray in color. And the next stage is stage of resolution, which occurs after 7 days. And the liver is friable in consistency and motile, and the fibrin and cell debris are digested by the enzymatic digestion. So all the alveolar spaces get cleared off by the defense mechanism. So we need to remember few differences between bronchopneumonia and lobar pneumonia. Bronchopneumonia occurs in extremes of age, and lobar pneumonia occurs in middle age, that is 20 to 50 years. The bronchopneumonia is secondary to other disorders, whereas lobar pneumonia is primary. It occurs in the healthy individuals. Both these conditions caused by the bacterial infection. But most common organism here in case of bronchopneumonia is Staphylococcus aureus, Streptococcus, and Haemophilus influenza. In case of lobar pneumonia, that is 95% of lobar pneumonia is caused by pneumococcus pneumonia. And here grossly there will be patchy consolidation. Here there is diffuse consolidation of the lung, and this consolidation is seen around small airways, and there is no limitation by the anatomic boundaries. In case of lobar pneumonia, the inflammation is limited by the anatomic boundaries. In case of bronchopneumonia usually bilateral, lobar pneumonia is unilateral. So this is lobar pneumonia and this is bronchopneumonia. This is diffuse consolidation of the lung, consolidation of the lobe of the lung, and here there is partial consolidation, patchy consolidation. And this is diffuse consolidation. Here there is patchy consolidation. So coming to the complications of pneumonia. So the first one is abscess. Abscess is nothing but localized separate-to-necrosis. Usually the right side of the lung is usually involved in case of aspiration pneumonia. And the common etiological agents are Staphylococcus, Klebsiella, and Pseudomonas. Pleuritis or pleural effusion can also occur. Pleuritis is nothing but inflammation of the pleura. Usually occurs by the Streptococcus pneumonia. In case of blood-rich exudate, which is present within the pleural space, it is usually caused by the rickettsial diseases. And the next one is empyema, first in the pleural space. And septicemia, with a bacteremic dissemination to the heart valves, pericardium, brain, spleen, kidneys, or joints, causing metastatic abscess, endocarditis, meningitis, or separate-to-arthritis. And the last one, organization of the exudate resulting in the fibrosis. So this is the gross picture of abscess formation, and these are all the abscess cavities filled with the pus. The freshly cut specimen, you can see the yellow colored pus discharge within the abscess cavity. This is also the lung abscess. This is a large abscess cavity. This is the microscopic picture of the abscess, which contains innumerate neutrophils as well as the fibrin deposition and few macrophages here and there. This is also the microscopic picture of the abscess. This is the abscess cavity. So thank you. This is the end of the session. You can exit.